All right, everyone, we'll go ahead and get started on the abdominal and genitourinary injuries chapter. This is another trauma chapter. And then at the end, there will be some questions to try to reinforce some high yield concepts. And so let's get going. So the abdomen would extend technically from the just superior to the diaphragm all the way down to the pelvis. And so this is going to contain digestive, urinary, reproductive uh, organs. And so in a lot of vessels, a lot of blood supply goes to the gut. And so that's kind of what we're talking about today. And so, you can get significant trauma to the abdomen can occur from a blunt trauma, penetrating trauma, or both. That is intuitive. Now, unlike the chest, the abdomen is not protected by ribs mostly. And so you run the risk of, uh, you know, for damaging some of these relatively soft and fragile organs within the abdominal cavity. And so that's where we see some of these injury patterns, like a ruptured spleen is very common in trauma, major trauma, because the spleen uh, is somewhat protected by the ribs, but not entirely. Okay. And so injuries to the abdomen that go unrecognized or not repaired in surgery are a leading cause of traumatic death. And so you'll hear the phrase referred to as like a hot abdomen, and that is because blood is hot, and as it bleeds into the abdominal cavity, it can create a warm temperature along with peritonitis, and so and it'll be rock hard, like guarding the abs. The stomach will be hard to touch because of the peritonitis, and so it's kind of just a reiteration that that's what it'll be called in slang, as a hot abdomen. So we divide the abdomen into four quadrants, okay, and so a quick review. Of course, this is the patient's right. So we'll start in the right upper quadrant. On you, that would, and on the patient, that's the liver. And the liver is very large, and it takes up a large amount of real estate up in the right upper quadrant, and it butts right up to the diaphragm. The diaphragm's like this, okay? But if you were to feel up underneath your rib cage, you can feel a little bit of the liver, about a centimeter of it, a little bit more on some people, and so that is the liver. And up underneath the liver is the gallbladder. And the gallbladder is the thing that it stores bile. The liver itself produces bile. Bile is used in the emulsification of fats. And so it'll hold this green-like substance in the gallbladder, and then it has a duct that'll dump it into the first part of the duodenum, or the small intestine. And so, of course, the little bit of the colon is up here in the right upper quadrant. So just to trace the colon, you have the ascending colon, transverse colon, descending colon, sigmoid colon, and then the rectum. And so in the right lower quadrant, you have the appendix. That's probably the most notable thing down here in the right lower quadrant, is the appendix, because sometimes we can have a condition called appendicitis, where the appendix will get inflamed and infected, and sometimes it can even blow up and perforate and leak GI contents into the stomach, or into the abdomen. Okay. Left lower quadrant, you have the descending and sigmoid colon. This is probably the most common places you'll get issues in cases of like diverticulosis, diverticulitis, constipation. All of that will present over here, usually on the left lower quadrant. And then the left upper quadrant, namely, you're going to have the stomach. The pancreas is below the stomach, so the pancreas looks like this. Okay. And then the spleen. The spleen sits up in the left upper quadrant. Its job is it takes old red blood cells out of service, basically. So it looks at old red blood cells. There's macrophages in there that will chew them up and recycle them. And so there's a lot of blood supply that goes to the spleen. Okay. And so the right lower quadrant is a common site for like pain and swelling and issues of the appendix. This is a medical issue, not a traumatic issue. But remember, the appendix sits here, right? So it's this little pinky-sized structure that lays off the end of the cecum. So basically, all your bowels your small bowel goes from your stomach, goes through all this, and it eventually will dump right here. The ileum will join the large intestine, the colon, and this area right here is called the cecum. Off the cecum is the appendix. We don't need the appendix to live, but we still have it, and sometimes it becomes infected and inflamed, and we'll have it removed surgically. Okay. These are cadaver images to show you what it actually looks inside of a human. These are dead humans that have been preserved, but this would show you what this looks like, right? And so the hollow organs hollow means that they have air in them, okay? And so this would be like the stomach, intestines, ureters, and the bladders, right? And so those are them. And when I say bladders, because there's the gallbladder and the urinary bladder, okay? And so when ruptured or lacerated, contents will spill into the peritoneal cavity. And remember, when anything like blood or pus or white blood cells or urine or poop or whatever touches the lining of the abdominal walls, it becomes irritated and it creates a condition known as peritonitis. Okay? And so, I'll just show you this. I think this is a little bit of an easier picture, but here's the lungs, heart, lungs. There's the diaphragm right there. Okay? This looks like it. This is the stomach. Okay? This is a chunk of the liver on this side. This is going to be the colon right here. All right, these are all loops of small bowel. Up underneath here would be the pancreas. You might be able to see a little chunk of it. Pancreas would look like that. That's pretty much what you would need to know. Now, hollow organs, they're connected by this thing called the mesentery. And so this is mesentery. This is small bowel, but this is mesentery. And it's like got this fatty stuff with all these vessels that come off of the main mesenteric arteries, the inferior and superior mesenteric arteries, that branch off and feed the vessels of blood supply. So it's important to know the blood vessels the abdomen is very rich in blood supply because this is where food digestion takes place. So you need a lot of blood flow here to A, to facilitate digestion, and B, to absorb the nutrients from that. Okay, and so contents of the small intestine, and so the mesentery also helps anchor stuff to the abdominal wall, and it helps anchor it. That's probably the word, right? And so patients with injuries to the mesentery can bleed into the peritoneal cavity. So you can imagine someone taking a 12-inch steak knife to this, right, is going to bleed a lot. Those are arteries you're looking at. And so they would bleed a lot. And so that's the issue with a mesenteric injury. And so this shows you again the hollow organs, the stomach, the bladders, the colon, the small bowel. Those are even they're saying the uterus. Yes, it is hollow. Those are all the hollow organs. Solid organs are going to be the kidneys, pancreas, spleen, and the liver, and the ovaries in women. Okay. And so the liver or the solid organs like the liver, spleen, pancreas, kidneys, ovaries, right? These do like chemical work of the body, so enzyme production, blood cleansing. This would be like the liver and the spleen. Energy production, the liver. Okay, and because of the rich blood supply, the hemorrhage can be severe. So all of these organs are very rich in blood supply. I would say, yeah, all of them actually. I'm not going to say one's more than the other. It kind of depends. Injuries to the abdomen are considered either open or closed, so that's pretty intuitive, and they can involve hollow or solid organs. And so blunt trauma to the abdomen can be from motor vehicle collisions, motorcycle crashes, falls, blast injuries, pedestrian versus bicycle, pedestrian versus car, we call those autopeds, rapid deceleration, compression like asphyxiation, right? All of those. And blood in the peritoneal cavity produces acute pain in the entire abdomen. And so the inside of the abdomen innervation for sensation is not like the innervation of our skin or anywhere else even. And so your organs are not well innervated for sensation. And so this is why we get issues of referred pain or nonspecific pain or dull and achy pain or like for example, if you have peritonitis and it's really to the right lower quadrant, you may feel that across your whole abdomen. And it's the way the nerves are designed and cross within the abdomen and the organs themselves. And so what you'll see sometimes with these closed abdominal injuries is abdominal distension. What's distension? The abdomen gets distended. It gets big. It gets large. It's often the result of free fluid, blood, or air, or organ content spilling into the peritoneal cavity. So this is like a very extreme form of bloating, right? The abdomen gets very hard and distended, okay? And then you could, of course, get abdominal bruising and discoloration. Now, seatbelts, they can cause blunt injury to the organs of the abdominal cavity. And so if you were to draw a seatbelt on yourself, of course, it's going to go across the chest, but it could very well cross, your liver, your stomach, your small intestines, and then definitely across portions of the small bowel and more importantly, the bladder. the urinary bladder. And so this is why you have to worry about urinary bladder issues with people that wear seatbelts and have like rapid deceleration, i.e., going 60 miles an hour and hit a brick wall, because the as they move forward, the seatbelt's trying to hold them in their seat, and so you can explode the bladder, especially if it is full. And so that can happen in anyone, but especially in pregnant patients, or also, if you don't know, the uterus sits right on top of the bladder. And so when you are, so if someone's pregnant, then you could also injure the uterus or in the fetus inside the uterus from a seatbelt as well. With that said, it is still better to wear a seatbelt than not. Okay. And so we should remember to inspect the, beneath the airbag for signs of damage to the steering column. So when airbags shoot out and they deflate, they cover the lower part of the steering wheel. And so a good practice is to lift up that airbag and look at the steering wheel in its entirety and see like, oh wow, the bottom half of the steering wheel has been bent in because the patient's lower abdomen hit that. You know, so that's something that you should do, is look at the whole steering wheel in its entirety. And in order to do that, you're gonna have to lift the deflated airbag up and look. Okay, that's what they're showing you. You know, and so if you put these in the incorrect position, like it's sitting too high up on your abdomen, that's a problem. This is sitting way too high up. It's even up on the chest. So really, you know, you want lap belts to go across the lap, and so this should go across like the interior pelvis. So an open abdominal injury is what it sounds like, right? You've opened up the abdominal cavity, and so foreign objects can enter the abdomen and open peritoneal cavity to the outside. Open wounds can be deceiving. They're very frightening. I've only seen a handful of these in my career, and maintain a high index of suspicion. So it takes a fairly large amount of blunt energy to get this to happen, like a very large amount. But you know, the abdominal wall itself is fairly thin, relatively speaking. And so we have a discussion on bullets. And so, you know, like low velocity injuries would be knives and other edge weapons. So maybe like a pickaxe or I don't know, something like that, a knife. And then medium velocity is going to be small caliber handguns and shotguns. So for a size comparison, you know, these are all handgun rounds, and these are shotgun rounds. But usually, the shotgun rounds contain either pellets or a really big slug, and so it kind of depends. But there'll be multiple bullets inside of a shotgun round. And then high-powered rounds are going to be your rifle rounds, right? And so these are usually, I mean, they're the thing about a rifle round is they travel way faster. So that's what makes the rifle rounds way more fatal, relatively speaking, because they can travel a lot faster. Okay, and so I just put that there for size comparison. So handgun rounds tend to have a little bit of a larger bullet in comparison to how much powder's behind them. And then rifle rounds have a little bit of a smaller bullet with a ton of powder behind them. So they move really fast when they get shot out the barrel. And so we've talked about the issue of cavitation. I'll put a picture of it right here. I put it on the wrong slide. But anyways, this is cavitation. And so the bullet enters and it creates this temporary cavity, right? And this is called the permanent cavity, but it actually will go further than that in the temporary cavity. And then the bullet fragments when it's in here because it loses its energy or it'll hit stuff and it kind of explodes, and then it'll exit. And so that's something to know. That's called cavitation, okay? That can very commonly be tested. That phenomenon of bullets creating a cavity is called cavitation, and it's from the pressure wave from projectiles that transfers into the tissues. And so the low velocity injuries, these are going to be like stab wounds, also have capacity to damage the organs. Very obviously, if you get stabbed with a 12-inch butcher knife, right, it's going to damage the internal organs. Internal injury may not be apparent. So what does that mean, right? You may just see a little bit of a stab wound externally, but you slice through their colon and inferior mesenteric artery, right, and they are bleeding to death in their abdomen. But all you see is just a clean little surgical looking cut. And so these can be deceiving. If injury is at or below the xiphoid process, Assume it has affected the thoracic and peritoneal cavities. What's the xiphoid process? That's this little point down here at the bottom of your sternum that points off. So if I were to draw the sternum, it looks like this, right? This little thing right here is called the xiphoid process, right? This thing. And so that's kind of like the line of the diaphragm. So if you get stabbed there or something happens there, you might have to assume that that got the peritoneal cavity, the thoracic cavity, or both. Okay. Now, evisceration, I showed y'all this. There's a picture coming up. Remember, evisceration is when you have bowel that's protruding through the abdominal wall, or any organ really, but typically it's bowel, will be protruding from the abdominal wall. And so it can be painful, and it's visually very shocking to see someone's guts hanging out. And I've seen this, um, as a paramedic, and of course you see it in surgery. And so uh, the idea is we don't push down on the abdomen. You don't push anything back into the wound channel. You would cut clothing around the wound, and you'd perform only a visual assessment. Palpation and stuff like that, like touching, is not necessary at that point. And so we'll talk about how to treat that, but basically you'll cover it with a moist sterile dressing. And so hollow organ injuries often have delayed signs and symptoms. So what are the hollow organs? Stomach, intestine, bladders, gallbladder, urinary bladder, colon, those things. And so the thing about these hollow organs is they tend to hold stuff, right? Like the bowel, the small bowel holds food that you partially digest. The bowel holds poop, or the colon holds poop, right? So you can imagine poop or food being dumped into the peritoneal cavity. That's going to cause a huge problem and lots of pain. Or imagine the stomach acid in your half-eaten beer and Taco Bell leaking into your abdomen. That's a problem. It's going to create severe pain. And so these are the issues that you'll run into, that these stomach and intestine contents can be highly toxic and acidic into the peritoneal cavity. So of course you're going to get peritonitis along with infection and all these other issues, okay? And so infection becomes a real issue when you rupture a hollow organ. And so when you have rupture of a hollow organ caused by blunt or penetrating, the blunt organ will kind of pop, right? It's like it's opening up, it's popping, and it's releasing the fluids and air into the peritoneal cavity, and so that will cause peritonitis. And so penetrating injuries cause a direct injury, but a blunt injury, like being hit by a car or a baseball bat to the abdomen, can pop due to the sudden pressure increase, like a balloon. You're popping a balloon, and you can release the contents into the abdominal cavity. And so now the gallbladder and urinary bladder contents should be sterile, right? But they're still annoying and damaging, right? This isn't like as bad as losing your stomach contents in your abdomen, or the bowel contents, like poop, and like literal poop from the colon in your abdomen, but it is still a problem if you bust the bladder of the urinary bladder or the gallbladder. And so air in the peritoneal cavity will cause pain. What do we call that pain? Peritonitis. And it can cause further can cause ischemia. What's an infarction? What's the difference between ischemia and infarction? Ischemia is the cells are starving for oxygen, O2. Infarction is the cells have starved to death from oxygen, from lack of oxygen. And so that's the difference. And ischemia is you're on your way to dying. Infarction is they have completely died. And so this becomes important with chest pain, right? The difference between ischemia and infarction. And so solid organ injuries, they can bleed a lot. What are solid organs? Liver, pancreas, spleen, ovaries, kidneys. Those are all solid. And so they can be hard to identify from physical exam, and they can potentially slowly ooze into the peritoneal cavity. And so you can get like a liver laceration or a spleen laceration that's relatively small, and while it will continue to bleed and cause problems, in the immediate term, it's just kind of oozing blood in the peritoneal cavity. But the same thing, you can have a large laceration or a large laceration to the liver or spleen, and it will pour blood into it. So it really kind of depends. But no, sometimes the cuts are small and sometimes they're big. And so if they're big, obviously they're going to bleed more. And so the liver truly is gigantic until you see one. It takes a while to appreciate how big it is. But the liver's huge, right? And so it's very vascular. In fact, all of the blood of the guts has to travel through the liver before it can come out to the other side to make its way to the heart. What vessel do they travel into? The portal vein, right? So all of your small intestine, all of your colon, with the exception of the rectum, all of that will have to go through one vein and up through the liver to exit to go up to the heart. And so you can imagine how much blood flow is coming to the liver. It's a tremendous amount of blood. Okay. And so when you hear of someone having like a fractured right lower rib, or penetrating trauma to the right upper quadrant, then you need to be thinking, oh gosh, the liver's there and that's really vascular. That's a problem. Okay. Now, I've drawn this before. This is a patient. This is their diaphragm. Here's their liver. Okay, it's the patient's right side. Well, the nerve that innervates the diaphragm is the phrenic nerve. And so what happens is when the liver gets injured, it will irritate the diaphragm. And what the diaphragm nerve will say is like, oh, well, this hurts. Let's send pain signals. Well, it sends pain signals, and this runs right up through the right shoulder. So you will feel that pain up into your right shoulder. Okay. So that's you see that with gallbladder issues, that you certainly see that with liver issues when the liver is bleeding, and that is an example of referred pain. You're feeling pain in your right shoulder even though the injury is in the right upper quadrant. Okay? As an example of referred pain. And so the spleen and pancreas is on the left side, and so the spleen can be injured from blunt trauma, fall from heights, right? Handlebar accidents where the handlebar goes into like the upper abdomen, lower chest. And they are very, very vascular. And the spleen itself is very soft. It's just like a big chunk of fat, right? And so it's so soft it can bleed a lot and it can rupture or not rupture, but kind of like cut itself. And so that's something to be aware of. But the spleen itself is very, very, very vascular as well. And so you have to worry about bleeding with that. And so I would draw the same guy. Let's just go back. Well, the spleen sits here, right? This is the spleen, and the pancreas feeds into the spleen like this, okay? And so there's vessels that feed the spleen that go this way. And so what happens is if the spleen gets injured or it's bleeding, you can get what's called a Kerr's sign. And the same thing happens. You'll bleed onto the diaphragm here or cause irritation to the lining of the diaphragm, and it'll line up through the phrenic nerve, and you'll feel this pain in your left shoulder. That's called Kerr's sign. It's indicative of splenic injury. Now, I talked about this in the last video, but there's this thing called diaphragmatic rupture. And so the diaphragm is fairly thin. In real life, it's actually thinner than what you would think. And so on the patient's left side, it's the patient's left, this is the patient's right, there's liver right here, right? Here's the liver. And so this is the diaphragm, like here. That's the diaphragm, where the diaphragm's supposed to be. And so what happened was this guy probably sustained like maybe a steering wheel to the abdomen, right? Or a horse stepped on his abdomen or something like that. And he increased the pressure so much in his abdomen, it shoved his guts upwards. And when it did, the lining of this was thin enough, or there was a pre-existing hole, to where it shoved the bowel contents up into his chest. And so that's called a diaphragmatic hernia or a diaphragmatic rupture. It's called a diaphragmatic rupture. And so how this will present, besides major trauma, is it'll present with bowel sounds in the chest. So when you listen to lung sounds, you hear bowel, you don't hear air coming in and out. So obviously this is a surgical emergency and they would need to go to the OR. And so they're going to exhibit dyspnea. Dyspnea is the medical word for shortness of breath because they have bowel sitting in their chest and not lung, or the bowel's pushing on the lung. And so this creates a lot of problems for patients. So the kidneys, obviously, these will sit in the retroperitoneal space. Again, very, very rich in blood supply. And so the hallmark of a kidney injury, whether it was a back shot in a tackle football game or what, is the patient will be complaining of blood in the urine. And so if the patient is urinating blood, that's a big red flag that, okay, we need to look into the kidneys and make sure they're okay. Okay. Now, that's blood into the urine, meaning you only see this blood when they urinate. But there's something else called blood. Okay, blood visible on the urinary meatus, right? Blood visible on the urinary meatus indicates significant trauma to the genitourinary system. And what this typically more so means is injury to like the urethra, the penis itself, or the bladder. But that can happen. It would be very rare for you to have a kidney injury and for you to just be pouring blood out the meatus without urine mixed into it. So anytime you hear that there's blood on the urinary meatus, right, or the tip of the penis or something like that, you need to think more than likely that's a urethral injury. The urethra is what carries urine from the bladder to the outside world. Okay. Assessment of the abdominal. So we're talking about patient assessment now, right? Assessment of the abdomen is actually really difficult. Again, it's because the abdomen's poorly innervated, so the patient can't always say like, no, it really is my stomach. It's like right here is where it hurts, right? And so that's the hard part of this. And so this is where we use index of suspicion and mechanism of injury to our advantage to try to help aid us in our differentials. And so, the patient may be overwhelmed with more painful injuries, because, for example, like you're in a car wreck and you broke your femur, but you also happen to have abdominal injuries. The patient will be screaming louder about their femur than their abdomen usually. Okay, and so this is why we do full body exams and we palpate and assess the abdomen, because again, those are called distracting injuries. When you're focused on someone's broken femur and you never even looked at their abdomen that is like rock hard and hot and they're bleeding into their abdomen. Okay. So scene size up, standard precautions, call for safety, call for help. Observe the scene for early indicators of mechanism of injury. Okay, is there a ladder that's tipped over that's a 16-foot ladder, right? Did they fall off of a 12-foot roof? What's the story? So we're looking for our clues. Consider early spinal precaution. Consider all the injuries the MOI could have produced. So that, again, this is where we have to be detectives and use our intuition to put together what could have happened, should have happened, would have happened prior to us getting there. And quickly form a general impression and note the patient's level of consciousness. And so, again, we use the AVPU score. Severe external hemorrhage must be addressed before airway or breathing. Remember, that's why it's X, A, B, C, D, E, right? So if someone's shooting blood, we need to address that. Now, while we're talking about blood, can we fix abdominal bleeding outside of the hospital? No, you cannot. You cannot fix abdominal bleeding outside the hospital. So we don't use wound packing. The only thing you can do is cover it with a dressing, or or an occlusive dressing. That's all you can really do. Okay, there's nothing you can really do to fix that. They need to go to the operating room and ensure that the patient has a patent airway. And so, you would treat shock aggressively, transport them to usually a high-level trauma center when you suspect abdominal trauma, because again, their hope is a trauma surgeon or a surgeon in general to come help them, because ER doctors can't fix this. They usually they will have to go to the operating room if they have injured an abdominal organ. That has to be fixed in the operating room. So investigate the chief complaint in the MOI, identify signs and symptoms, and remember pertinent negatives. These are the things like they have abdominal pain, but they do not have blood in their diarrhea or blood in their feces. They do not have vomiting. They do not have nausea, but they do have abdominal pain. That's a positive, and that's pertinent. But a pertinent negative is the things they don't have that need to be told with the story. And so the hallmark of peritonitis is movement of the body or abdominal organs irritates the peritoneum, causing pain. And so when you see a patient with peritonitis, any type of movement will usually irritate them. Okay, and so you'll notice that like when you are hitting a bump in the ambulance, oh, they'll be like, ow, right? Like, or you're just going over the threshold of a door with the wheels of the stretcher, like boom, boom. They're going to be like, ow, ow, right? And so it hurts. And so movement tends to exacerbate peritonitis, and so they have pain with movement. Now, again, they're going to have pain with palpation. So if you push on someone's peritonitis, first they're going to have guarding, where they're flexing their abs to keep you from causing them pain, one. Two, they're going to have rebound tenderness sometimes. What's rebound tenderness? That's when you push on the abdomen, and that's going to hurt, but when you let go abruptly, it hurts even more when you let go. Okay? Sample OPQRST, ask if there's nausea, vomiting, and diarrhea. And so again, if they have abdominal pain but they don't have nausea, vomiting, or diarrhea, we still need to mention those as our pertinent negatives when we're giving our report. And so the reason that you want to know about nausea, vomiting, and diarrhea is, okay, well, has it been a lot? Do we need to worry about hypovolemia? Does it have blood in it? Do we need to worry about hemorrhage? Do we need to worry about airway concerns? If they vomited 10 times in the last 30 minutes, right, from some type of trauma, you need to think, oh, they're going to vomit when they go unconscious and start dying. And so they're going to choke on their vomit. So that you have to worry about their airway, okay? And so, something that's important to ask in both medical and trauma patients are using the restroom like normal, right? And so patients should use the restroom generally number 2, around 3 to 4, up to 7 to 10 times a week. The real answer is it hard? And so that's what you would ask, like when you poop, is it hard? And if they're like, no, it's normal, then that's fine. But when feces becomes hard, that's when you start worrying about constipation, just to kind of go off a little bit and talk about that. That's really, it's not as much as how often are you using the restroom. It's more so, what does it look like, and is it painful? Is it hard? Is there blood in it? Stuff like that. So remember, secondary assessment. You may not be able to perform this in the field if you don't have time. But during this is our more of a detailed exam. You're going to inspect for bleeding, remove or loosen clothes that are exposed to the injuries, right? Patients should remain in a position of comfort. We should keep patients warm as well, and examine the entire abdomen. We'll show you how to do a focused abdominal exam in history in class. It's very important to know how to do that. Everyone gets pretty good at listening to lung sounds and stuff, but then we suck at abdominal exams, and they're very important to know how to do. So remember, with the DCAP BTLS, we're looking at our abdominal quadrants and we're thinking, well, what's underneath that? And if it's so I'm thinking like, oh, wow, they have severe pain in the left upper quadrant. Then I'm thinking, okay, spleen, gallbladder, colon, stomach, something like that is hurt. I'm not thinking about the appendix at that point. And so you're using that to aid you. And so as you're palpating and you're noticing stuff in a certain quadrant, you're thinking, oh, well, then it's probably this, or this. And then so that's where we start. That's why it's important for you to know the quadrants and what's underneath each of these. Because obviously in a human, this is just a flap of skin. And so you have to know, like, oh, there's a spleen, there's a stomach. So you have to know that. And so you want to palpate the quadrant that's furthest from the offending thing, from what's offending them, okay? And so what does that look like? And so let's just say they have right lower quadrant pain. Let's say they have appendicitis. You don't immediately go up and touch this with your hand. If you do, they're going to be guarding for the rest of the exam and the whole thing's shot. So you start, like I would start up here, then over here, and then over here. Just start in the opposite corner away from where you want to end up at. So for example, they have a big bruise to the left lower quadrant. This is all bruised up. Don't go and touch the left lower quadrant first. You would touch up here, and then up here, and then up here, and then you would finish down here, okay? And so that's something to know when we do abdominal exam, okay? And so palpate the quadrant furthest away from the quadrant exhibiting signs of injury or pain. I just said that. This will allow you to investigate the possibility of radiation of pain, and it also allows you to keep them from immediately guarding anytime you touch them, okay? So you can't palpate the kidneys very easily. You can palpate a little bit of the right one, and it's not easy, okay? And I'll show you how to do that in class, but um, it's not easy to palpate the kidneys. Let me say that. You can ballot the kidneys, right, to where you'll kind of bang on them, right? And if that elicits pain, it could mean like hydronephrosis or kidney injury, but that's not a common thing to be doing anymore, but it's something you could do. And so just be aware of the kidneys area for tenderness, bruising, swelling, or other trauma signs. What's the hallmark of a kidney injury? What will happen? The patient will urinate blood. Patient will urinate blood. Okay, and so you have to worry if you blow up the kidney or some, or really anything. If you blow up one of these organs, they're going to leak either blood or stomach contents or poop or food or something, urine. It's going to get leaked out into the peritoneal cavity, and so that causes all sorts of problems, peritonitis, infection. Okay, so these are the patients you'll frequently reassess and do vital signs on. What you'll end up with is a form of hemorrhagic hypovolemic shock, and so you'll end up with a increased heart rate and eventually a decreased blood pressure. Okay, remember blood pressure is a late finding. Okay, so how does that present? 22-year-old lady involved in a major front end collision, was wearing her seatbelt. She has a rigid abdomen that is noted to be exquisitely tender upon palpation, with guarding noted. Her current set of vital signs are respirations of 22 and anxious. SpO2 is 94% on room air. Her blood pressure is 92/62, and her heart rate is 133, right? And so you'd think like, oh, well, that sounds like she's going into shock, right? So that's an example. And so isolated abdominal injury can certainly occur. This is more of a medical thing, but it can happen traumatically, sure. You can get a blow and just whack out the left kidney or something like that. But visually inspect the abdomen for penetrating wounds. This will happen more common with like a knife wound, like a low energy thing, like a single knife wound to the kidney or something like that. I don't know. And so if the entrance wound is found, check for the corresponding exit wound. So we don't always have exit wounds, but sometimes we do. And then, as always, we never remove a impaled object unless it interferes with CPR. And you're going to reassess. Don't have anything to add on that. Now, for closed abdominal injuries, what you really want to do is get them to the hospital, but our treatment per se is to monitor and evaluate for the progression of shock, and if they go into shock, to treat shock. But really, it's a diesel bolus, right? Take them to the hospital so they can see a trauma surgeon or a doctor. And so the patient may experience nausea and vomiting. If this happens, you have to worry about them choking on that vomit if they were to become unconscious. You might have to administer oxygen to these patients who are unconscious or in shock. Remember, it's usually 94 or less. You will percent on the SpO2. You'll administer oxygen. You'll assist ventilations when necessary. Consider calling ALS for gastric tube placement. No ambulance that I know of carries gastric tubes anymore. There's a reason why. You can put them in the wrong place, right? And so, or if those organs are perf, they can end up in the wrong place. It's just not done very often. Now, patients with penetrating injuries, generally they'll have obvious wounds with external bleeding. Maintain a high index of suspicion for serious unseen blood loss. Remember, some bullets might have very small entrance wounds and exit wounds, but they cause this huge cavitation inside. So same thing with stab wounds. It just looks like this, but they were stabbed with a knife this big, right? And so they have these huge injuries inside. We just can't see them. So this is where this whole index of suspicion thing becomes very important with injury. So you do want, someone would probably have spinal mobilization. You do want to assess the back, not just for spinal issues, but is there a gunshot wound to their back that we don't know about? Is there, burns to their back? Is there a rash? Is there blood? I mean, what's going on in the back? And so that's something that we would use clinically, and that's another reason why we roll patients is we look at their back. Now, again, if a penetrating object is still in place, let's say there's a big steak knife sticking out of someone's left upper quadrant, we don't remove it. Not only remove it unless it interferes with CPR. And so what you do is kind of like one with the eye. You would wrap that in place or try to secure that in place to where it doesn't continue to move. Because remember, every time it moves, it could be cutting and causing further injury. So we just try to stabilize it where it's at. With a bulky dressing is usually how you do that. And so that's an evisceration, right? Those are loops of bowel sticking out of this guy's chest. And so this is bad. This yellow stuff is the mesentery. There. Okay? And this is the small bowel. So what do we do for this, right? We never push it back into the cavity. We keep the organs moist and warm. We cover with a moistened sterile dressing, secure dressings with a bandage, and you secure the bandages with tape. So here's what that looks like. You have an evisceration. You got filleted up at the city limits bar, right? And then you're going to cover this with a moistened sterile dressing. Then you're going to cover, cover with a moistened sterile dressing. And then you're going to cover it with a dressing or bandage on top of that. And then you're going to tape it on all sides. Okay? Do we push it back in the cavity? No. The big thing that I would stress on this that I think people might actually forget is you want to keep it moistened. Keep it moistened. And the majority of your dressings are already sterile, but don't forget that detail, the moistened sterile dressing. So moving on to the genitourinary system. So that was abdominal injuries, right? So again, know your quadrants. You're going to get tested on that. We're going to run scenarios on that. But moving into the genitourinary system, these obviously, the genitals control reproduction, and then the urinary system is obviously the discharge of waste and water. And so they're obviously located within the abdomen. So the male genitalia lays externally. The female genitalia is internally within the pelvic cavity. That's pretty intuitive. I don't think I need to explain that. But a quick review of the male reproductive system. So this is the urinary bladder. And so let's start at the testicles, actually. Testicles, epididymis, vas deferens. Okay, testicles is where sperm is produced. These will travel through the bladder and they meet here in the prostate gland, where the prostate gland is a smooth muscle that will contract at ejaculation and mix with seminal fluids to cause ejaculation through the urethra and out the tip of the penis. And so that is the general flow of ejaculation. Now, the bladder itself is fed by the ureters. The ureters are coming from up here in the kidneys, right? And so that's something to know. Yeah. Now, so it's external genitalia. And interesting, humans are, we default to female genitalia, and males will express male genitalia because of their chromosomes. So it's very similar. Like, these are the equivalents of testicles in men. They just didn't descend. And so you have the ovary. This is where eggs are produced, right? And so every 28 days or so, one will pop out, be caught in the fimbriae of the fallopian tube, come around the ampulla, and dump into the uterus. The uterus is a smooth muscle. This is the uterine cavity. And here is where the walls of the uterus will enrich to prepare for receiving a baby. Down here is a cervix, okay? Cervix means neck. And then this is the cervical opening, and then the vagina to the external world, right? And so that's how that works. Now, something to point out is the uterus is kind of inverted on top of, so like vagina, and then the uterus goes this way, okay? So it's kind of at like a 90-degree angle like that. That's what's supposed to happen. It doesn't always happen that way. And I just showed you that's the bladder. The uterus is this, my bad. So remember, kidney injuries, these will happen. You know, the classic vignette is football player gets tackled in the back and they're pissing blood 30 minutes later, right? That's the classical example of a kidney injury. Now, this can certainly happen from blunt or penetrating trauma. You don't need to know these classifications, but the kidneys are incredibly rich in blood supply because they filter the blood. And so just know that they can bleed a lot. And so the hallmark of a kidney injury is blood in the urine. And this can lead to shock. And the kidneys also lay in the retroperitoneal space. So they lay behind the main abdominal contents, and they sit in this back compartment, okay? And so you don't get peritonitis in the retroperitoneal space, by the way. So that's something to know. So it's not the same type of pain. So sometimes these kidney injuries are relatively painless compared to like some of the other things. So abrasions, lacerations, or contusions to the flank. What's the flank? That's this area on your back, okay, on each side. Penetrating wounds to the flank or upper abdomen, fractures on either side of the lower rib cage, and or lower thoracic and upper lumbar vertebrae area. Again, right about where your kidneys are. If there's injury there, you should suspect kidney injury. A hematoma, a what? What's a hematoma? It's a bruise. It literally means a mass of blood or a blood mass in the flank region. Now, urinary bladder injuries, again, these can happen from seatbelts, and so they can blow, like when people get in a wreck. And so you would spill urine, which is sterile, should be sterile, into the surrounding tissues. This creates peritonitis and issues, and you got to reconstruct the bladder at that point. So that's a big deal. But that's not going to be terribly fatal. But maybe the blood loss and reconstructing the bladder, those are pretty big. Reconstructing the bladder is a really big deal. Okay. And so again, in males, a sudden deceleration can shear the bladder from the urethra. What does that mean? So if you have a seatbelt here, right, that's coming across this guy's lap, and you suddenly decelerate, if that seatbelt pushes down hard enough on this, you can tear the urethra, like inside of the penis, it'll tear. And if that happens, what do you see, right? What do you see with urethral injuries? I told you, blood at the urethral meatus. So you'll see it up here at the tip of the penis. There will be blood, okay? So that's worth knowing. And so, you know, bony fragment. Okay, the pelvis, if it breaks, that takes an incredible amount of injury to break the pelvis. Not the hip. This is the hip. When someone says they broke a hip, they broke it here. But the actual pelvis itself, lots of energy to break the pelvis, but it does happen. Just kind of rare. But you can get some of these contents stuck up into the bladder. I think this would be exceptionally rare, but it can happen. Okay, and so that would be a ruptured bladder at that point. So soft tissue wounds of the male genitalia, rarely life-threatening, more so painful. So I'm told should not be given priority over more severe wounds unless there is severe bleeding. And so, again, don't let these be distracting injuries. Right, the patient was involved in a large collision, and they're complaining of penis pain per se, and they're bleeding at the tip of their penis a little bit, but they also have bilateral open tib-fib fractures, right, or something like that. Like, don't this isn't usually what I mean. It's an issue, but it's not a huge is the biggest issue probably in the case of multi-system trauma. And so the pain can be referred to the lower abdomen. So if you don't know, like people, again, poor innervation, like people will have a kidney stone, which would be down here in their bladder or their lower abdomen, and they'll feel it in their scrotum, and vice versa. If any male has been kicked in the gonads, where do you feel that pain sometimes? Right up in your abdomen, and so it's similar. So again, that's one of these examples of like, oh, the nerves are kind of funky in the abdomen. Now, internal female genitalia, they're actually fairly well protected. This doesn't happen very well or very common, but you can technically rupture the uterus, especially in late-term pregnancy with like a seatbelt, but that would be rare, okay? For this to happen to someone who's unpregnant, to rupture or damage the uterus or fallopian tubes, astronomically rare. But in pregnancy, when they're very big and these walls are getting stretched out to their limits, yes, you can rupture them or you can damage or bruise the uterus. Okay? And it's also because the uterus normally sits kind of down in the pelvis, but when you're pregnant, it's like obviously way out of the pelvis. And so this is something to keep in mind. And if they are pregnant, you need to keep the fetus in mind because that energy was transferred into the fetus. Okay? And so they're talking about the anatomy of the vulva, which is the external, the clitoris, essentially the equivalence of a male penis. From a sexual and nerve standpoint, the labia majora and the labia minora, right? And so uh, the external genitalia of both men and women, especially men, is very rich in nerve supply and blood supply for the most part. And so uh, consider sexual assault in pregnancy. If there's external bleeding, remember, we don't really ever put anything inside the vagina, so all you would do is put a sterile pad on the outside of the vagina. We never insert anything inside of the vagina. So keep in mind that this is embarrassing, right? If someone were to have an injury to this, it's embarrassing. The best way to do this is with a chaperone and just say, hey, I need to take a quick peek. Is it okay if I look? And have someone back there with you. Make sure the windows are blacked out to where bystanders can't look in. Take only as long as you need to look to make your. It's only done by a visual exam. It's not done by touch or any other way. You only take a look. It's only looking. Okay, provide privacy, and if possible, like I'm working with a female partner and I have a female patient with where I need to look at their genitalia, I'll have the female partner look. That's the norm. That's the best practice. Okay. If it's two males, then you need, of course, every patient you need to get consent, but you need to have a chaperone. Somebody needs to, don't do this by yourself. Okay, not in today's age. It's too dangerous. There's too many weirdos out there. And anyway, scene size up. Assess for the scene safety. Make sure you're safe, right? Uh, Patient may provide the MOI that seems less embarrassing than the actual MOI, and so be aware that they may not tell you the full story because they're embarrassed. Again, these injuries will be embarrassed. For example, we're going to talk about you can physically break the penis with rough sex, right? So you know, you may not want to tell that. You may just say, I don't know what happened, or something like that. And so these are, or someone had a large foreign body in the vagina. Now it's bleeding profusely. They may not tell you that, right? It's embarrassing, and so it's taboo, and so stuff like that you might run into. So again, we just quickly scan. It is a visual inspection. That's it. I said this. It's very vascular, especially the penis. The penis itself is very, very vascular. That's how it becomes erect, is blood. And so, um, ensure that the patient has a clear and patent airway. Consider advanced airway if the patient's unresponsive. Sure. Assess pulse rate. That you could have shock from this. I think that would be rare, but it is possible. Now, okay. Let's say someone breaks their penis, right? Like their penis looks like this, right? It's at a 90-degree angle. You probably wouldn't want to take this patient to Medical City. I'll say at Weatherford, right? It's probably going to be like a Harris, John Peter Smith, a big hospital that's going to definitely have a urologist there and maybe some other surgeons to help with this. And they need to go to an actual trauma center, a full-blown trauma center that have access to urology. So history taking, some of the more common things you'll hear and things we could inquire about is, have you had any nausea, vomiting, any diarrhea, any blood in the urine, any vaginal discharge, any penile discharge, vomiting blood, abnormal bowel or bladder habits. Have you been going to the bathroom more often, less frequently, things like that. OPRXT. So again, ask about the patient's urine output. This is historically very unreliable without an indwelling Foley catheter because, I'm completely with it right now, and I'm doing a GI genitourinary lecture. I have no clue how many times I've peed today. I could say that it's pretty normal for me, but getting the specifics, I really don't know. Okay, so just think about that when you're interviewing your patient. They truly just may not know because it's not something we really think about. Ask about allergies, last intake of food or fluid. This is important for surgery. You generally don't want to have planned surgery. If they won't do planned surgery usually if you haven't been MPO for less than 8 hours. They want it to at least 6, 7, 8 hours of you not eating or drinking anything. The reason is when you do surgery on someone, there's a risk of them kind of passively regurgitating and choking on their vomit. So the genitourinary systems, this is your secondary system, may be awkward to assess and treat. Now, question: could you say have someone with a broken penis, right? A fractured penis, and you're like, okay, sir, is it okay if I do a quick visual inspection? And they say no. Is that okay? Is But you have to look, don't you? Right? No. The answer is yeah. They can refuse any part of our treatment at any point, and they can pick and choose what they do and don't want. And so yes, they could refuse you that, and so you just have to honor that. Okay. Make sure documentation is going to really cover you on this. When you do these inspections, you may want to document who was back there with you when you did this exam, right? So say, hey, both paramedic, Swartz and Harbold were present during the full body exam, including genitalia, and so you may want to document that, okay? Document anything that was said that was odd, right? So this actually, I won't go too deep into the story, but basically, let's just say it's a best practice if a patient says something that is odd, right? Like they allow you permission to look and then they're like, oh wait, don't look, right? Then that would need to be documented. Of patient gave permission and during the visual inspection she turned away and said she prefers not to be examined. So you would document that. Everything that was said, the exact details, okay? And so again, this is just protecting you in 2024. Like it or love it, like this is where we're at as a society, unfortunately. Now, I will say, overwhelmingly, patients are very. I've had one patient since I have been in medical school, and we do a lot of genitalia exams, like a lot. I did like 6 week of OBGYN. Um, I've only had one patient say no, and she was nice about it, and so that's fine. That's their right. So generally, there's so much trust in our profession, you generally don't run into issues with this, but it still needs to be documented. Uh, so kidney injuries, again, transport them. You may or may not see blood in the urine, but that is a hallmark sign of blood in the urine. Urinary bladder, again, or the urethral injury, you'll see blood at the urethral opening, so at the urethral meatus, at the tip of the penis. Okay. External male genitalia, if it's been lacerated, you would just cover it with a moist and sterile dressing. All right. If you have like areas of stripped skin, right, like an avulsion or abrasion. Now, if it's so, there is a very large artery and two veins, two arteries and a large vein that run through the penis, right? And so, if in a doomsday scenario, let's say someone chops their penis off, that's going to bleed an incredible amount. So you would have to apply direct pressure at that point, not a tourniquet, but direct pressure with a sterile gauze to control the bleeding. Never move or manipulate foreign objects in the urethra. That is a thing where people will stick like stuff in their urethra, so like through the tip of their penis, almost like they're putting in a catheter. And so it's like a sexual thing, I guess. And so don't take that out. Again, unless it interferes with CPR, we don't remove impaled objects. Leave it alone. That's someone else's problem to take out. So if you have avulsed parts, remember we put those in a moist and sterile dressing and place those in a cool environment and transport and put them in a bag and transport those to the hospital with us, okay? Managing blood loss is the top priority. I mean, I can't stress enough, you're opening up an artery to the outside world if this gets nicked, and so they would bleed a lot. This is what I was talking about. You can actually fracture the penis. And so this is usually almost always due to rough sex. And so, I mean, I've drawn it for y'all before. I'm not doing it. I'm not falling for that trick. I'm not gonna draw a penis on here, but you can imagine these penises can literally be at like a 90-degree angle or more. And so it's not an actual bone, the penis per se, but if you were to take a cross section of the penis, there's a large vein and two arteries. And so this vein will become engorged with blood, and that is what gives an erection. And so that's, you can snap these vessels essentially. And so what you would expect with this is intense pain, bleeding, fear, and severe bruising. It'll very quickly bruise. Laceration with the head of the penis, whether you get the skin or the foreskin caught in the zipper. If the long segment of the zipper is involved, you would cut the zipper out of the pants with heavy scissors, like trauma shears, okay? If it's a small segment in the zipper, you would just try to unzip it and free the penis. They would need to be transported, of course. But, in either one of those scenarios, I've tried taking them to the hospital. So urethral injuries are not uncommon in men, and so where you can get the reason is because urethras are really long in men, right? They go all the way from the bladder to the tip of the penis. Compared to the women, it's like a centimeter or two, and so you can get these in straddle injuries, right? So you can see this in skateboarders that are like trying to grind down a rail, and like they fall and they kind of like rack themselves up into a pole, right? And so they hit it. That's called a straddle injury. They're straddling something, right? Pelvic fractures, penetrating wounds of the perineum, right? All these, but those are the common things that will damage to the urethra. Okay, and so what's the hallmark of a urethral injury is blood at the urethral meatus, so blood at the tip of the penis. And so um, for foreign bodies protruding from the urethra will have to be surgically removed. I mean, it's pretty intuitive. Now, the skin of the scrotum is fairly thin, all things considered, and so that can get avulsed for whatever reason, caught in a zipper, or, I mean, sex or something weird. The possibilities are endless, right? But what you would want to do, and it's fairly vascular, what you would want to do is wrap that area, and again, in a moist and sterile dressing, and compress it, and transport them to the hospital. If you have like a chunk of avulsed scrotum skin, you would again wrap that in moist and sterile dressing, place it in a bag, transport in a cool environment with the patient to the hospital. Now, this is something that I don't know why like society finds this interesting, but direct blows to the scrotum can truly rupture a testicle. Okay, I know someone who has a kid who at school the kid got nut tapped. Right, someone just nut tapped him, and it ruptured. I don't remember the exact injury pattern, but he went to Cook Children's for like 4 or 5 days. They were worried if he was ever going to have kids. It's this huge hospital bill, all because of a nut tap, right? And so the testicles are obviously very sensitive, but I mean they're exposed, and so there's a reason it hurts so bad when you get trauma to the testicles. It's God's way of saying these are exposed. You need to take care of them and guard them, right? And so that's why you can get injuries to these pretty easily. Okay, very painful, and so the treatment would be apply ice to the scrotal area if they'll tolerate that. That's to limit swelling. Now, female genitalia, this could be for any reason, but you're going to hold the dressing in place with like a diaper type bandage. Remember, we never pack the dressings into the vagina. Do not fall for this. They'll be like, lady was practicing sexual fisting. She's bleeding an incredible amount of blood from the vagina. What do? It still don't pick packing. It's wrong. We do not pack the vagina in EMS. Okay? Not my opinion. It's wrong. Leave any foreign bodies in place after stabilizing with bandages. Again, this could be sexual things or abuse, or like an example is an autistic or mentally incapable person sticking like, I don't know, something in their vagina. It's not a sexual thing. It's just it's like something a kid would do. And where you also see this is in children, like very young children. They'll stick something in their vagina and it goes in, and they don't report it because they're not capable of reporting it, and so then they end up with this infection because there's a foreign body in their vagina. And so that's something to be aware of, that you can see injury patterns like that in the very young, very old, and the intellectually disabled people as foreign bodies in the vagina. Of course, you can see this for people for sexual gratification as well, but you can also see this incidentally in those groups as well. Now, rectal bleeding, this is a very common complaint because of hemorrhoids, right? And so hemorrhoids is engorgement of veins. We'll draw this. So if this is the rectum, right, what can happen due to straining is the veins in the walls of the rectum can swell. So these are just big veins that are sticking out. Now here's the outside world. So these would be external hemorrhoids. These would be internal hemorrhoids. And so these can bleed. Okay, they can bleed a lot, and they can or cannot be painful. It depends on the level, if it's above or below the pectinate line. And so hemorrhoids is a very common issue. These can bleed so much they can lead to shock, though. I should warn you. Okay. Now, sexual assault in the form of anal sex, again, and I'm not trying to be weird, but like fisting, for like large foreign bodies, things like that into the rectum could obviously cause rectal bleeding. Okay. And rectal prolapse as well. And so rectal foreign bodies, both again for sexual and non-sexual gratification, colitis, like ulcerative colitis, and then ulcers as well. Those are probably not as common, but if they do happen, okay. We've covered sexual assault, but this is a good reminder because this is a form of trauma, physical and emotional, right? But physical trauma, victims are generally women, but it can also be men, okay? So be aware of that, be sensitive to that. But is overwhelmingly going to be most commonly women, unfortunately. There's little you can do beyond providing compassion and transport. And so this is where being a good human being and listening and not asking a bunch of weird, invasive questions that aren't going to change anything between now and going to the hospital. So generally, I don't ask a lot of questions. I will listen. If they want to tell me what's going on, I'll listen. But generally, I don't ask a lot of questions because it doesn't change anything that I'm going to do. And so uh, now, if that's just isolated sexual assault, if it's they were severely beaten and sexually assaulted, obviously you're going to focus on those injuries well. But you get what I'm saying here, right? Usually knowing exact details of the rape or sexual assault are not relevant. Don't need to know them. Now, we don't. In this case, we don't examine the genitalia unless there's obvious bleeding that requires application of a dressing. Why is that? They've already been humiliated or abused or hurt, and so re-exposing them right to that uncomfortableness is just usually not necessary. The only time that would be necessary is if they're bleeding and you need to apply a dressing. So let me say that again. We don't need to inspect every vagina, every penis after sexual assault. Only the ones that are bleeding that might need a dressing. Okay? Generally, the patient will know this too, right? So you would ask them, like, okay, do you feel like you're bleeding? And they're like, well, I feel wet down there. And you're like, okay, well, do you feel like it's blood? Well, maybe. Okay, well, is it okay if we look, right? And so you could ask them, do you feel like you're bleeding? And if they say no, then case closed. Don't need to look. So there's a crime scene policy that'll vary from system to system. A lot of times this is their own protocol. But generally, I've talked about this, you don't want the patient to wash, bathe, shower, douche, urinate, defecate until after examination by a sexual assault nurse examiner in the state of Texas. And so, again, if oral penetration or fellatio or anything like that has occurred, fellatio is the word for oral sex, uh, the medical word for it. If oral penetration occurred, advise the patient not to eat, drink, brush their teeth, use mouthwash until after the exam. Again, this could wash away evidence, okay? And so you don't want to do that. And a lot of times it's difficult for the patient because they feel dirty, they've been violated, and so they want to get that off of them. But you might just have to explain the fact to them. Hey, we're going to the hospital. We are going to take off your clothes. There's going to be someone there that's specialized in this. It's going to know exactly what to do and exactly how to help you. So just compassion. You want to handle the patient's clothes as little as possible. Again, for DNA and stuff like that, you don't want to be wiping your DNA all over them if possible. And so make sure the EMT is carrying. So if possible, like say a female got sexually assaulted, uh, and I'm working again with a female partner, even if it's not even her turn, she's gonna have to take that call. It's just it's a comfort thing, right? And so that's the best practice. And I've never gotten pushback on that. If there's a female on scene and like even if it's like a female with vaginal bleeding and it's not female partner's turn to run the call, she'll probably still just run the call. It's like a courtesy thing to your male partner. It's a courtesy thing to the patient. It's just a best practice. It's being a good human being. And where I work, we have good human beings. Now, question time. Let's burn through these. Peritonitis would most likely occur from which of the following injuries? The liver, spleen, kidney, or stomach? So I'm thinking, I want to show a pattern here. Solid, 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 and then hollow. So sometimes when I don't know where to go on a test question, I'll try to find a pattern of like, okay, something's out of whack here. And I know the stomach also contains hydrochloric acid, which is a very, very, very potent acid that digests food. And I'm thinking acid on anything would hurt. So I'm going to think that it's D kidney or D stomach. And it is. Okay. And so it is D stomach. And so what I'm saying is I don't look at these questions. I promise you, I have not looked at any of these questions because I want to tell you my thought process as I'm going through and answering these, okay? And so I may get one wrong on here and that would be embarrassing, but it's what I'll do for science. So you can take pictures of these or pause it if you would like. Which of the following organs would be most likely to bleed profusely if severely injured? Liver, kidney, stomach, gallbladder. Okay, I'm gonna go liver just because of its size, and I know that all of the blood that comes from the all of this blood from your guts has to come up through one vein called the portal vein to the liver. And so that's a lot of blood that goes through there. So I'm going to go liver just because I know there, and it's a very big organ. It's the largest abdominal organ in the abdominal cavity. So I'm going to go liver. Boom. Okay. There's the answer if you want to read it. 40% of the body's total blood volume at any given time is in the liver. It's huge. I'm telling you, a lot of blood goes to the liver. Which of the following statements regarding intra-abdominal bleeding is false? So we're looking for the false statement here, okay? Intra-abdominal bleeding often causes abdominal distension. That's true, okay? So that's true. Intra-abdominal bleeding is common following blunt force trauma. Well, that's true. The absence of pain and tenderness rolls out intra-abdominal bleeding. That is not true. Okay, so I'm circling that. Bleeding may not occur immediately following blunt abdominal trauma. That is true. So I'm going to go with C. That you can have intra-abdominal bleeding with no pain or tenderness. Booyah. It's almost like I just taught this. Okay? Even when seatbelts are worn properly and the airbags deploy, injury may occur to the... No, wait. I would say the iliac crest. Okay. Even when the seatbelts are worn properly and the airbags deploy, injury may occur to the... That's a tough one because you could get them to all of these, but especially the chest. So I'm between. So the seatbelt goes across the chest, and a lot of times you can break ribs and stuff in the chest that way. The extremities, no, that's not from a seatbelt. That's only from the airbag. You don't know what that means. When you hold a steering wheel and the airbag pops off, usually it'll rub right here on the inside of your arms and cause injury. It can break your arms too. The iliac crest, I think that's a little hot, a little oddly specific. Lower rib cage, not really. You could, but I don't think that would be a common thing. I gotta pick one. I'm afraid I promise you I've not looked at these. I'm gonna go iliac crest, and I'll tell you why. Because if the airbag's deployed, that should protect your chest. That your chest should be protected from an airbag, but your iliac crest is always going to be exposed to the lower part of the lap belt. So let's see what they say. Booyah! Got it right. I didn't make a fool of myself. So there's the rationale. When inspecting the interior of a wrecked automobile, you should be most suspicious that the driver experienced an abdominal injury if you find, okay, a deformed steering wheel. It takes a lot to deform a steering wheel. So especially the lower part of the steering wheel, that can jack up the abdomen. So I'm going to say, yes, that could certainly cause a lot of injury. But let's read the other answer choices. The airbags that deployed, nah, that doesn't really do anything to the abdomen. A crushed instrument panel, no, again, that's going to be the chest. Damage to the lower dashboard, maybe, but I really think it's going to be a deformed steering wheel. The lower dashboard's complicated. That's more so your knees. So the lower dashboard is when it'll roll into your knees. So I'm going to go deformed steering wheel. And I am correct. Okay. Now, this one that I was stuck between, the lower dashboard, this will usually roll into the patient's knees. So the lower dash will go into the patient's knees. And so imagine when you're sitting in a car and like draw a straight line from your knees forward, that's the lower dash. And so that can cause damage to your knees, not your abdomen. Other than applying a moist sterile dressing covered with a dry dressing to treat an abdominal evisceration, an alternative form of management may include Okay, it's wrong to place dry towels because bowels will dry out. That's wrong. Cleaning the exposed bowel with sterile saline. I don't like that. No, it would need to be covered. Applying a pass. No, that would be awful. That's a pneumatic anti-shock garment. This is where it squeezes the legs and lower abdomen really tight to push air up or to push blood up into the thorax. Terrible thing. We don't use it anymore. We'll show you what it's like in class. We have one to show you. And apply an occlusive dressing secured by trauma dressing. I don't know about that one, actually. I think this one might actually be correct. I'm going to go with the occlusive dressing thing. Maybe wrong. I was right. Okay, so although the preferred management for an abdominal illustration includes the application of motion. Okay, so they're worried about body heat. Okay. Um, the only thing that keeps I know what occlusive dressings look like commercial ones, like a chest seal. They are so sticky. I couldn't imagine that sticking to a bowel, but of these, it is the best ones. Again, I'm having to go through like most right, least wrong. I'm eliminating answer choices to get to the right answer. So these are things I need y'all to do on your quizzes and exams. You are transporting a patient with possible peritonitis following trauma to the abdomen. Which position will he most likely prefer to assume? Ooh, I didn't tell y'all this. Uh, it's with the legs drawn up. And so you'll see this with people with peritonitis because it pulls less tension off of the peritoneum. I didn't tell y'all that. That's something that you might know with someone with peritonitis. So patients with peritonitis often want to lie still and have their legs drawn up. This kind of like unstretches the peritoneum. When you lie flat, it pulls the peritoneum real stiff and flat, you know. Patient was playing football and was struck in the left flank. I gave y'all this example. His vital signs are stable, however, he is in severe pain. You should be most concerned that he has injured his kidney. Left flank. Anytime you hear flank, you need to think kidney until they can prove something else. It's flank equals kidney. Flank equals kidney. It's going to be the kidney. So flank equals kidney. So what's a good indicator that there's actual kidney injury? The patient's urinating blood. I love a good medical terminology one. The term hematuria is defined as blood in the urine. Okay, here's the explanation. Oh, and so this is called hematochezia, blood in the stool. Vomiting up blood is called hematoemesis, and urinary bladder rupture will present with blood at the urethral meatus, or frank blood. Okay. When caring for a female with trauma to the external genitalia, the EMT should use local. Okay, when caring for the a female with trauma to the external genitalia, the EMT should use local pressure to control bleeding. No, that's very rare. Carefully pack the vagina to reduce bleeding. We never pack the vagina. Remove any impaled objects from the vagina. No. Cover any open wounds with a moist sterile dressing. Yes. I don't think you use local pressure. Local pressure means your hands are physically touching, and that's usually not the way we do that. We'll just put a pad. Oh no, it happened on the last example. It happened on the last example. I got one wrong. Okay, I'm cool. No, I'm not. Alright. When caring for an EMT, I think this one was referring to the penis. That's the penis. So where if there's an open wound on the penis, I think that's the one that you cover with a moist sterile dressing. I hate the word local pressure. Like you don't really apply pressure to the vagina or I guess the external genitalia is what they're saying. So this is more like the labia or clitoris or something like that. Okay, I got happened in 4K. You just saw it. So let's read the rationale since I don't know what the heck I'm talking about. So bleeding from an external genitalia should be controlled by applying a dry, sterile dressing and local direct pressure. That seems odd to me, but who am I? Never pack anything into the vagina to try to control bleeding. This increases the risk of infection and and anything you place into the vagina will only need to be removed at the hospital. Impaled objects in the vagina should be carefully stabilized in place and not removed. Now, um, I think this one, I remember this one, the one that I chose that was wrong, is for like a penis issue. You can like an avulsed where the skin, I think they said, got rubbed off on the penis. You could use that. So you caught it in 4K, folks. Got one wrong. Contrary to popular belief, I'm not perfect. I'm just kidding, but seriously. So anyways, the correct answer is use local pressure to control the bleeding. So with that, I'm going to go cry myself to sleep and end lecturing for the day. So y'all have a good day, and I appreciate your attention.